Good morning, class. I'm sorry I could not be with you today. I wish I could. Believe me, I wish I could. This is the lecture that takes place during class that is recorded. So I need you to watch the entire lecture because the parts at the end are kind of important as well too. And I will end up testing on some of these materials. So this is all about is really a study of how you study global health issues. From my own personal experience, I've done quite a bit of this type of work. And there's information to be gleaned from the study itself about what affects people's health related to water and sanitation, things like that too. But there's also some information about just methodologies. How do you go about doing a study like this? And that's what I want to focus on today. So we're going to take two case studies out of Honduras and Uganda that really represent several research papers combined as well, and we'll draw some conclusions toward the end. Now, before we get started, it's important to make define a couple of terms because you'll see why in just a little bit about how critical these are. If you don't understand what you mean by health, and if you don't understand what you mean by community, you're going to have a hard time understanding community health, obviously. So these things have to be clearly defined in your case definitions and all this stuff in these studies, and so I'm going to help you with that right now. But health, as we've all talked about before in class, is according to World Health Organization's 1948 definition, a state of complete physical, psychological, and social well-being, and not simply the absence of disease or infirmity. Now, we all hold to that, at least verbally. But when we actually talk about people's health, we tend to lapse into the absence of diseases. But what do you mean by community? All right, and again, you'll see why that's so critical in just a few minutes. Now, when I began to study this, I was asked by Water Missions to design a study to measure the health impact of a large water and sanitation project in Honduras. It was a PENTAIR grant that provided water and sanitation to, we believe, around 320,000 people, a huge, huge study. And in order to measure that, first I began to look back at the literature as a whole for water and sanitation. And this is a meta-analysis by Futrell and Colford. And if you're not familiar with a meta-analysis, what that means is you take a whole bunch of studies and you try to combine them into one study. It's a very complicated process. And they did so, I believe this was a World Bank funded paper. And what they found was really quite, they found so many of them were such poor quality they had to reject them. And they were because they lacked adequate control groups. And if you're going to compare people's diarrhea rates, for instance, will fluctuate a lot. How do you know they're getting better or worse because of what you did if you don't have some type of control group? So these, in the overwhelming majority of studies, there was no control groups at all. If they did, they weren't randomized at all. And if you don't randomize them, then you can't control for confounding variables or confounding factors, again, that you might think that you have an effect or don't have an effect when you really do or you don't. You have to control for those kinds of things. And these studies just did not have them. They didn't even define their health indicators very well. And in most cases for water, you're talking about diarrhea, okay? And not always, but most of the time that's what you're talking about. That means you've got to define what that means, and you got to tell them over how long a period of time. So for instance, if you tell them, have you had diarrhea in the last 72 hours, that tends to be pretty accurate. Up to 2 weeks tends to be pretty accurate. But if you ask them if you had diarrhea in the last year, that's a terribly inaccurate tool. Or ask them how many times they've had diarrhea in the last year. Terribly inaccurate tool. We've known that for a long time. So they, if they had health indicators that lasted long, recall indicators that lasted longer than 2 weeks, they got rejected. So Safe Water Cologne was a project in Honduras. You can see the state of Cologne right here, and it's a very large state in the middle of the country of Honduras. We initially were told they had a population of about 280,000 people. It turned out they were way off. We did our own surveys for that, and it turns out the population is about 378,000 people. And PENTAIR had tasked us to get water and sanitation to everybody, to not leave anybody out of it. And we came pretty close, as close as you could possibly do in something like that, by building 203 community-based community-managed safe water systems. That's what you're looking at right here in this picture. That's a water filtration system. Most of them run on solar, some of them are on the grid. All of them now are on the solar. And that provides water that's perfectly safe. And I'm pretty picky about the water I'll drink, and I will drink water out of these taps. And by the way, we tested the water supplies. We tested 614 water supplies before we started this project, and 100% of them tested positive for coliforms. That means there was fecal contamination within the water supply that the community was drinking from at the time. We also installed around 16,000 flush toilets in outhouses. Those of you who've been to water missions have seen these. This is actually not one of them. This is actually made of plywood. They're now made of solid cement. And as a result of this, now 250,000 people or more in Cologne have access to the water treatment systems. And I'm not sure about the exact number for flush number. So I'm a fan of looking at things in multiple different ways. Okay, so it means if I hold up this coffee cup and I look at it from this side, I've got a picture of the Colosseum in Rome. If I look at it completely on the opposite side, I start seeing totally different things. And the only way I know this cup really well is to look at it from multiple different ways. And I approach everything like that through the research. And so what I designed was a 3-part study. First were these classic qualitative measures. We call them ethnographic data. And that's simply asking people, do you feel better? That's what they tell you. And that's what most of these studies that the World Bank study rejected did. They simply were asking people, do you feel better after this? And that type of study, including CAP surveys, is fraught with problems, not the least of which, if you asked people, do you feel better now that I've done what I've done for you, the overwhelming majority don't say yes to that. They just, you'll just see that as you work in developing countries in particular. So but we did huge numbers of surveys and things, and I'll come back to that in a second. But also we got permission from the Minister of Health to access directly people's health records. Of course, we gleaned those. We went through a full IRB both here in this country and in Honduras, and in Uganda, and we gleaned all that of identifying information so we can use the medical records when preserving patients' confidentiality. And then, so what we postulate is this: if people, when I ask people, when we put the water treatment systems in and the toilets in, are you having less diarrhea, or you're healthier, you're more productive at school and work, and if it's true that it does help those things, they'll say yes to that, and that'll show up in the ethnographic data. However, if it's also true, then what we should see is fewer people coming into the medical clinic looking for treatment for these diseases, if it's true that they came from the water systems. Then also, to make it even more objective, is if it's also true that it came from their water systems, that when we test them for certain waterborne parasites, there should be fewer of them. So what people tell us, what the medical records tell us, and then what we see from the specimens obtained from the patients, those 3 things give us a fairly accurate view of this. And I will tell you ahead of time, too, that when I've designed these studies, and I talked to Dr. Green, the CEO of Water Missions, who had hired me to do this work, I said, you have to understand, there's a good chance that we won't find anything, because it's such a, we're ruling out what other people rule in, which is this false data and false impressions. And he said, and I said, we may not find what you're looking for. He said, if we don't find an impact, that just means we have to learn to do it better. And you have to really respect an organization that has that type of attitude, because I published all this data, including some negative things about we found in the data as well too, and they respect that. I had complete control, as any reputable researcher should, of this data. So anyway, that's the 3 parts to the study. And so for the ethnographic part, or the interview part, we took from the existing construction queue, we created different categories of communities. We selected 12 communities, randomly, literally pulled them out of a hat or a bucket, and they're in 3 categories. One category, they hadn't had any intervention yet. They're going to, but hadn't yet. We could not, you recall from your ethics training we've already talked about, you can't actually withhold something from somebody that they otherwise should get in order for them to participate in the study. These communities did not. So we pulled 3 out that were not, they had no intervention yet, but they were going to. They just hadn't gotten to it yet. The other ones is a category communities where they had water systems installed already. Then the third one was where they had water systems and the flush toilets. So we had those three categories of communities. And from that, we recruited volunteers in all 12 communities, and this is one of the ethnographers here doing these studies. He's fluent in Spanish, much way better than mine is. We also conducted 12 focus groups, interviewed 46 individuals, and all of our informed consent was recorded. Their interviews are recorded, everything's recorded and translated, sometimes translated more than once, and transcribed. Then that gets entered into a narrative analysis software package, and I use Atlas TI as the software package for me. It's just these are fairly labor-intensive things, and anyway. And these are the kinds of things that people would tell us. They say, well, they're talking about the water system, we had it for 1 year, and we haven't done that bad. We've seen change in health between those who drink the purified water and those who don't drink. And that's, again, what you'd expect to see. And the amount of children with parasites has decreased very much. And when people go to the central, the health center, they go for problems like fever, grippe, but not for parasites. They're talking about waterborne parasites. Then another interviewee says, look, the people have always tolerated to the maximum extent diarrhea in young children, including even the adults, but now less with the purifier. So they're reporting to us that they're feeling better. All good news, all expect. Then this person says many results because there are almost no children with diarrhea nor adults because the entire city, it's a fairly small city, is drinking water from the purifier. And then one day, this was a pretty interesting story. This guy says, one day, the water at my house stopped working, so I went to work, and when I got home, I drank from the tap. Okay, that means that instead of drinking purified water, you drink water straight from the tap, which is already shown to be contaminated. As a result, we got diarrhea, my kids, my wife also, and everyone. From that day, I learned a lesson. We understood that clean water is really important. It is a necessity, not a luxury. Then this person said, we've seen reduction in diarrhea before. There's more, but that's for the purifiers. There's always diarrhea, but not as much as before. What we'd say. And I just like this quote. There's no life without. And again, this is Atlas TI. All that data gets entered into this package, and you can see these. We look for associations. We can track thoughts according to where they are on a map, and all sorts of things that I'm not going to get into today. That's about a whole course by itself. And then one of the things we also look for, and I call this a sign of a cultural shift. And this is Ron Delaney from UCLA was working with me at the time, and he asked this person, but can I ask you, if you go to a friend's house and they offer you something to drink that's not purified, do you drink it? Now I want you to think about what he's doing. He's actually, this is a stress test. He's asking you, if you go to a friend's house and you turn down a cup of water from that person, that is a major cultural faux pas. And that's an insult. Are you willing to stress your friendship in order to avoid drinking water that you don't believe is safe, or you're not convinced is safe? And the responder said, well, here the majority of people that are friends had purified water and use it. Then Ron asked him, what if they don't use it? Then he said, then we don't drink. Now, I don't know if you can appreciate that, but that is a huge finding that we're seeing where there's this cultural shift where people, they're willing to stress their friendship in order to make sure they drink safe water. Now, you would too. If you saw somebody pick up a cup of water out of a mud puddle in their front yard and offer you a cup of water, you might for the rest of your life question when that person asks you water. But here, that's a fairly new thing. So that's the subjective part to it. Then we got consent from to do medical chart reviews, and this is what the medical chart system looked like. And it's almost as much fun as it looks like to go through. So the way they do these are household charts, and they're stored in the reverse sequence of when the person came in last. So when I start to the top left and work my way across that row, I'm going backwards in time from yesterday's to last week's and so forth. So we then took and reviewed, after we obtained consent from the Minister of Health, we began to look at the number of diarrhea rates. We found that very high diarrhea rates in Cologne compared to the rest of the region from information we can gather elsewhere. So we pulled 311 consecutive household charts at this one medical clinic and reviewed them in reverse order, newest to oldest, and frankly, we just ran out of time. And the previous surveys know that the average household was about 4.5 people. So that meant that we were somewhere in the range of 1,400 individuals. And this is the number of one of the things we do first, by the way, is we look at the total number of visits across that period of time, and this is over a 7-year period of time, just to see if they stayed constant. Because you might see more of diarrhea because you're simply seeing more patients or more people coming into the clinic for whatever reason. And it turns out it's relatively stable. In real life, these are always noisy curves, and what you're seeing here is this kind of noisy curve left to right. That little spike in April was a dengue fever outbreak. It didn't have anything to do with water systems. And then we began to track the number of people that came in with potential waterborne illnesses, diarrhea, dysentery, or something like that. And what the red line is the actual numbers, and what the blue line is a 2-month moving average to kind of smooth it out. And I want you to look at this. Right here is where the water system was put in. That is a huge drop in the number of people there. Again, this little uptick here, I think it's just the noisiness of the curve, but there's a huge drop in the number of people coming in for waterborne illnesses contemporary with when we put the water system in. So that's the medical chart review. Then we go to the objective measure, and that's where we set up these remote labs and do what's called their rapid tests for these 3 waterborne parasites. Now, I picked these 3 primarily because I could do rapid tests for them. They were commercially available at the time with Cryptosporidium, Giardia, and Amoeba. And we call them rapid tests, but they're not that rapid. A lot of it depends on how large of a centrifuge you have. But we had, at this time, a fairly small centrifuge, later upgraded to a larger one. But they're fairly simple tests that I could teach people to do in the field. And so we found about 1/3 of the people had one of the 3 parasites. So 29% had one of the parasites. When we broke it down by the type of parasites, it's a little bit of a surprise, but we found it was about a little over half the people had Amoeba, and very few people had Cryptosporidium, and a good number of them had Giardia. The Giardia didn't surprise me, the Amoeba species actually did. Then we looked at whether or not they were positive or negative based on if they had access to a water system, or any type of energy, water system and the flush toilets. And we had 100, and what we found was a significant. Then we found this interesting result. So when we broke it down according to, when we looked just back at the water systems, yes or no, we had a big difference. But then we broke it down with the control group. They haven't gotten the water yet. Almost 35% had a parasite. If they only had water, 13.5% had parasites. But look at this, we had water and flush toilets. Instead of the number of parasites going down, the number of parasites actually went up. Now that's a big surprise, particularly since putting in a toilet system costs per person about 14 or 15 times as much as getting water systems and does for them. So this looked bad for us. We're thinking, well, holy cow, you're giving people toilets that are making things worse for them. So that was obviously a big surprise. We saw that developing in the field. So what we did, then we broke it down. So first we broke it down and further by gender. Again, found a little bit of a surprise. In the control group, more men have the parasites than women. In the water only, more men than women. But look at there, where there's water and toilets, it reverses itself. That gender differential, which is present, by the way, not just our study, lots of other studies, reversed itself. So there were more women that had parasites if they had flush toilets available to them than there were men. Again, let me just review this again. This is kind of important. So the control group, that means they don't have anything done yet. There's slightly more men than women that have parasites. In communities where they had access to treated water, again, more men, that's the water only groups, there's more men have parasites than women. But when you look at the ones that have water and flush toilets, it reversed itself, significantly reversed itself. There's way more women with parasites than men, so what the heck's going on? In order to figure this out, we sent our ethnographic team back into the area and began to ask all these questions and what's going on. Turns out, in this family, guess who cleans the toilets? Well, it is not those young men and the head of the household. What you're looking at is the lady of the household and the older girls. We believe that had something to do with it, so water missions went back in. and made sure everybody had long-handled brushes and all the equipment to take care of the toilet systems. And when they did that, and sure enough, what we found was that gender differential went completely away. So that now when you look at in the second round of specimen collection a year later, we found that where there was no intervention, about a fourth of them had a parasite. I forgot to mention, by the way, when we detected somebody with a parasite in this study, we collected parasite samples from them at the beginning of the study, then a year later. At the beginning of the study, if you showed positive with a parasite, we treated you with tinidazole, which is a very effective anti-parasitic drug. And what we're trying to do is bring the prevalence numbers down to 0. So that a year later, when we go back and study that same population, if you had a parasite on the second test, we would consider that part of the 1-year incident level. These parasites stay around for a long time. So if you were negative, if you were positive initially, we treated you, or if you were negative and you showed a positive the next time, you got that during that 1-year block of time. So in the second round of studies, we found a fourth of people had parasites in the control group. They don't have water or sanitation yet. If they only had water, 4.5% had parasites. If they had water and flush toilets, that number went to 3.8%. There's not much difference in 4.5 and 3.8, but at least it was not an increase. So what looked to be a negative effect of the toilets had since disappeared. Maybe it's from the cleaning, something else. So then we broke it down, and again, this gets a little complicated. So the red is the first year, okay? Blue is the second year. So first round of tests, the control group, 43% had parasites. In the group 2, where they had water only, 16.4% showed have parasites. And then in the group 3, 11.5% had parasites. That's if you took out people who did not show up for both the first test and the second test. All right, so I'm going to say that again. So when we exclude people from the study who we could not find to get specimens from them both during the first round of testing and then a year later, we exclude those people. So if you just showed up for the first round of testing, we excluded you. So when we do that, what we're doing is we're adding a temporal component to what we define as a community. And that means you have to live there for at least a year. So when we do that, what appeared to be a negative impact from the toilets also goes away. All right. So 43% first year, 16% second, 43% in the first year with control groups, 16% in the water only groups, and 11.5% in the water and sanitation groups. Come back a year later, everybody's been either you tested negative or you've been treated with tinidazole. You come back later, now a fourth of the people in the control groups have parasites, 4.5% have in the water-only group have parasites, and 3.8 have parasites in the water and sanitation group. So what that, again, we've got to know what we mean in what do we mean by community. So if we have only a geographical boundary, it means it's a snapshot in time. These are prevalence numbers. Remember, we talked about prevalence versus incidence. What you're looking at is it appears that adding the toilets increases the number of parasites. That makes no sense to anybody, obviously. But if you add a temporal component to it, it means you have to live there for at least a year, then we get a totally different result. Again, defining your unit of analysis is everything this time. So now I want to switch this over to Uganda. All right. We had another grant from a donor organization to do a very similar work. Minus the toilet section, but very similar work on the shores of Lake Victoria around Jinja. It's pretty cool that where we stayed, we could walk to the origin of the Nile River. Probably one of the coolest places I've ever worked. Very fun place to be, actually. And this is our initial research team. We had brought 2 different teams because we did space them out over a year. And did the same thing. We did the ethnographic data, we did the parasite test, and we did general health surveys. So initially, this is what we're looking at. We had 6 communities. These are the number of people, the number of homes, the number of people per home. So these are the population estimates we're looking at. So about 14,000 people. catchment area. This is what the communities look like. We actually stayed across the lake, which you can see here in Jinja. But we cross the lake every day to the communities we're studying, and this is what the communities look like. Very poor areas. One of the difficulties here, and I warned the people at Water Missions on this, is that it would be pretty easy just to get parasites from access to the lake itself, because as you can see, people are in this water. They're in this water all the time. So we then randomly sample the communities by using satellite imagery and assigning household numbers and things like that. So we did representative random sampling to make sure we get enough people with distances to the borehole and the lake and those kind of things. And we did the same thing. So we did ethnographic. The research arm was actually much larger than Uganda, where we did over 2,500 photographs and videos. We conducted 16 focus groups, 142 unguided interviews. And what I mean by that is, I'll have a list of questions I want people to answer, but if you really learn to do an interview correctly, you don't have to ask them those questions. They'll get around to telling you where they get the water and things like that too. You just let them talk and let them free flow information, because you learn so much more about the communities in doing so. And that resulted in about 110 hours of taped interviews, recordings. All that got translated word for word from Uganda into English, and sometimes we actually had to do that, go back and forth several times to make sure the interpretations were correct. And that resulted in, actually, it's now higher than that. It's about 750,000 words, about 700,000 words of narratives. We then conducted 169 CAP surveys, and all that data gets entered into Atlas TI, same narrative package for us. And then we did some ethnographic, just normal demographic data, how many people in your household, how many people are adults, and what's the main source of income. We're looking to find out if their source of how they make a living puts them at risk. And this is one of the CAP survey questions we asked in the last 3 days, again, limiting our recall to 72 hours. Did anyone in your family or your household drink, not just get water, drink from these sources, the borehole, a spring or wells or open wells, the lake, the treated water, rainwater system, or bottled water, those kinds of things too. Normal CAP surveys. And we asked yesterday, did you wash your hands? If yes, when did you wash your hands? And then we were also looking for authoritative sources of knowledge, where you learn to do these kinds of things. There's a government worker, a family member of the radio, and things like that too. We're looking for ways we can tap into these authoritative sources to teach people. Then we asked them, when's the last time you cleaned your gear? Do you have access to latrines or not? Who owns the latrines? And if they said yes, we own one, they asked, can we take a picture of it? And the photograph was taken with GPS coordinates. Of course, all this was approved by the Minister of Health through IRBs, both here in the States and in Uganda as well too. And this is the Atlas TI. We asked them things like, do you use traditional medicines? And we're looking for linkages, traditional medicines to water supplies and things like that too. And again, looking for these associations, and also just doing a simple thing of finding out what's important to people. When you do these unguided interviews, you go back and count the number of times people mention a health problem. It's a fairly decent indicator of how important that health problem is to that person, or in some cases, we pool it to the community. And for instance, they mentioned tuberculosis and malaria a lot, and diarrhea and dysentery. But just counting the number of times brought up in the conversation is a good measure of how important it is. And then we also wanted to look and find out, was there evidence that the water missions training was entering into the thought processes and the practices of the community? So we played around with different ways of accomplishing that. And one of the ways we finally ended up with is we asked a simple question: do you know why chlorine, and these are different brand names for it, is used in some sources of water? Like, by the way, your water here in the United States is all chlorinated. Do you know why? And if they just answered yes, then we asked them to explain. We didn't ask for any details. Basically, if they had an explanation that had anything to do with organisms or diseases or hygiene, we answered it, we labeled it as correct. And that answering correctly on that correlated very strongly with an economic scale that we also created, and therefore we thought we were onto something. The economic scale is things like, do you have a roof on your house? Does anybody have access to a motorcycle? And those kinds of things. Do you have electricity? And then about half the community gave a correct answer, and the bottom line is we actually could not find any evidence that the training that Water Missions was doing was penetrating into the community's thought process. So here's some of the results that we found in the objective part. We found, or the subjective parts, the interviewees had a high level of knowledge related to health and water issues. You'd think, by the way, everybody always says you need to educate people on these things, you got to educate people on these things. The fact is, in Uganda, everybody knew where they got the diarrhea. They all knew the water system was contaminated. They all knew that. Knowledge does not necessarily translate into power to change something. So just because they knew it doesn't mean they can do anything about it. But we found a very high level of knowledge related to health issues, specifically water. In fact, way higher than we saw in Honduras. And this is an example, by the way. So we would ask these people about these diseases, and they said, well, we are fishermen, we go to the lake, we get worms through the legs. Now, those of you who've been in my class, you hope that you recognize what that is. That's schistosomiasis. Remember, the snail produces the little parasite lives in the snail, it gets free swimming, and eventually you're swimming in the lake or wading in the lake, and it penetrates your skin. And they know it. This guy knows. Most medical doctors here in the United States would not recognize what he's talking about, which is schistosomiasis, but he knew that. And in fact, they all knew that. And they're describing various schistosomiasis. Then they're talking about bilharzia, another term for it, and they know it comes from wastewater flowing into the water that they use. They're aware of this. We're supposed to teach them. But we also found that waterborne illnesses were just not that high of priority in these communities. When we started talking to them about what they're actually worried about, a lot of stuff, but mostly they were talking about malaria. They were talking about tuberculosis. They were talking about HIV. And frankly, when you looked at how they're actually dying, they were right. Waterborne illnesses were fairly low, at least fourth or lower on the rankings of things that they were worried about. If you think about that for yourself, you can't worry about everything. So that means you're going to prioritize what you worry about and what you intervene with for your own health. In this case, they were worried mostly about these three illnesses, and they were correct about those. And they talk about how they knew the mosquitoes were transmitting malaria, and they were worried about malaria, tuberculosis, cough. Again, that's what they're concerned with. The other thing we found way more profoundly in Uganda than we saw in Honduras was that time management is a huge problem. There are long queues for people to get water out of these wells, long queues, hours and hours and hours. And I mentioned in the class before that I did a study once when I was in South Sudan where I measured the amount of time the ladies were spending gathering water. They're spending 6.5 hours a day just doing water, 6.5 hours a day. And you think about it for a minute. If you took 6.5 hours of your waking up time per day out of your schedule to do something as basic as gather water, what else could you do? You could not be in school. You could not probably have a job. You really could do very little except take care of your household by getting them water. So time management was critical in how people access this water. In fact, there's this one lady that I saw getting water from this muddy open spring, and I asked her, is this well safe? And she knew what I meant by that. And her answer was, it is not safe, but it's close. So she's opting in favor of time savings over the concern that the water is going to make them sick. Women and children bear the brunt of this. These kids are carrying water back to their households at very, very young ages, and they're working just really hard to get water back to their households. I mean, and sometimes it's some extreme. Look I don't know how old this kid is. Was he 3? And he's carrying this. He's struggling to get some jerry can back up to their house because their mom told him to. There's also a long history of poorly maintained water systems, latrines, and other types of intervention. It's hard for nonprofits, sometimes of very well-meaning people, to understand how damaging that is to a community. You go in and just dig a well because I want to give these people well, but you don't have a system set up for maintaining it, who pays for maintaining it, who has control over it. Eventually the system breaks and they just leave it. And pretty soon the communities just develop an attitude where they're not going to maintain anything because they never have in the past. And that goes to just wells. And also lake water access made it very difficult to measure an impact in Uganda because these kids in particular are in the water all the time, and that water is highly. And you look at these kids, they're just, and there's no way they're not getting that water. In fact, when we looked at the number of parasites, look at this age 3 to 5 group right here, they have the highest number of parasites. Not a big surprise. And the moms are in there with the So we looked at the number of where they got their water. Most people got their water from a borehole, second only to the treated tap. A few people got some bottled water. But the rainwater and the lake water were still very commonly used. And sometimes these are mixed up, by the way. These are not necessarily social water. What that meant was when we broke it all out, is about a third of the people in the last 72 hours were using water that I couldn't say was safe or not for them to use. So we looked at what other things they use water for: bathing, washing clothes, cooking, washing utensils, and the tap water was fairly low. The lake water dominated the rest of these categories. And people are using lake water for other things. Bathing, washing clothes, not so much. Cooking, maybe it's according to what you're doing with it. Washing utensils, not so good. You look at 2/3 of people washing their utensils with lake water that's highly contaminated. Access to the latrines, which you're seeing here, is very spotty and inconvenient all over this region. So people practice open defecation all the time. This is a typical latrine, really decent latrine. So then we looked at the parasite. We went in and we set up these, again, remote labs with, fortunately this time, larger centrifuges and a little bit better emulsion equipment. And we did the same thing. We looked at these 3 waterborne parasites. And I just showed this picture just to tell you that I remind you. I do microscopy on some of these samples, primarily just to confirm that the rapid tests are accurate. So if I'm seeing Giardia, for instance, in some of the microscope, and I'm not seeing a rapid test, there would be something wrong with the rapid test. And it turns out the rapid tests were quite accurate. I just can't do that many. I can't do 1,000 microscopic exams, which you do in triplicate, by the way, in the field like that. Just time wouldn't allow us to do it. So the rapid tests work great for that, and I confirmed it with the microscope. What we found was actually a lower parasite level than we found in Honduras, about 15% tested positive for a parasite. Again, remember it's about a little over 30% in Honduras, and that's out of 854 specimens. The mixture is relatively the same. Again, Cryptosporidium, fairly unusual. Entamoeba dominated, and Giardia came up number 2. Not very similar to what we saw. Then we broke it down according to these communities, whether or not they had some type of intervention. We had a total of 854 studies. And what we found was, again, I've showed you this before, we broke it down by age group. Younger kids had way more parasites. We didn't test people under the age of 3. And the reason I didn't, because to treat someone less than the age of 3 gets really complex because of the approved medicines that we could use. So we did not look for something that I would not be allowed to actually treat in the field. That's just bypass issues. Then we also looked at whether or not they were having symptoms of diarrhea, which was pretty interesting. Most of them said no. And even if they said no to that, saying no to diarrhea didn't predict whether or not they had a parasite, which tells me that the parasites they had were chronic parasites, not acute ones. So whether or not they had a history of diarrhea in the last 72 hours, we found no difference. We looked at the diarrhea rates among different socioeconomic groups, and we found no significant. We looked at diarrhea rates between the control groups, where they had water, and test groups, whether or not if they were closer to the lake. Did that make a difference? No. And so we basically could find no differences in the parasite levels with people in communities that had water systems versus not having water systems. So that did not look too good for us. So then we did this medical, tell people that's what the medical clinics look like in Uganda. I always tell people, if you ask me, if you're going to go to work with me in the field and I ask you to do the medical chart reviews, you should just run. So that's my wife on the right, and she's doing these reviews, just going through one line at a time, these charts, and it takes forever to do these. And they ended up doing about 19,000 total patient records, a massive review, and they found 916 possible waterborne illnesses. 858 were diarrhea, the rest were. And here's what we found. The red were the control groups, and the blue the test groups that had water systems. It looked like we had fewer, at least on the high end of it, looks like we had way fewer diarrhea cases in the medical chart review in the communities that had water systems versus the ones that did not have water systems. So they all looked like really good news. This is one of those moments you kind of wish you'd stopped reviewing the data, but I didn't. Back went further and did a different kind of analysis, looking at the incident rate ratio. And what we found was that difference was there already. In other words, there was no significant difference in the communities that had water systems versus the communities that did not have water systems. We're looking at just normal shifts in diarrhea rates between the communities, so no significant. We broke it down by education levels, age distribution, economic scales, distance to the water source, distance to the lake, ratio, if one was closer than the other one, all these different ways we broke it down by profession. And no matter how we broke it down, we could find no difference in the parasite levels between the control groups that did not have water systems and the test groups that had access to treated water. Could not find any difference, dramatically different than what we saw in Honduras. So why no measurable impact? Why did we see this massive impact in Honduras, but we did not see a comparable impact in Uganda? In fact, saw no impact in Uganda. Well, now if you're a public health person, that's the question you're going to ask. But if you're an anthropologist, like I also am, then you'd ask a totally different question. Why would you expect them to be the same? Because they're dramatically different communities. They're as far apart as on the globe as you can get even. They're ethnically different. They're ecologically different. They're culturally different. There are a lot of differences. But why would you expect them to be the same? Let's just look. So why would there be no differences? Maybe there's a design flaw. Well, I designed these studies myself, so I'm going to say no to that, and I think these are well-designed studies. Maybe the people in Uganda didn't have sufficient knowledge to do the right thing with the water system. But actually, remember what we found? No, they had a higher knowledge base in Uganda than Honduras. Maybe it's a random occurrence, but the statistical power of this study was huge. What about confounding environmental factors? And I think that's where we mostly are right now. There's things that made it look like there was no impact in Uganda when there may have been an impact in Uganda, or things that blunted the impact in Uganda. One was, we mentioned earlier, the repeated exposure to the lake water. The other was they were using anti-malarial drugs all the time, and some of those anti-malarial drugs have activity against the very parasites we're using to test. And also there's household exposure, which I think is this is a kitchen. I mean, there's animals in the kitchen. They're cooking around these things all the time. And just because you're drinking pure water doesn't mean you don't get diarrhea or parasites from these other sources. Remember, the water's not therapeutic, it's preventative. The cattle all over the place. And by the way, you always want to take one medical so he can do a test for you. The cows are in the I sent him out to gather specimens. He's really happy about this, to find out were the cattle carrying some of the same parasites. The answer is yes, they were. And there's cattle feces everywhere. They even will sometimes stucco their houses with cattle feces. The meat is exposed to the flies, the fish that they eat. Same thing. There's birds walking through the fish that they're eating. They're just contaminated everywhere. Now this picture tells an incredible story. I want you to look carefully. If you look here, this little child right here, this kid right here, see if I can get this straight. This kid right here, he's defecating in the water. You can't tell, but he is. This kid right here, he's urinating in the water. This mom and kids are gathering water from that same lake to take back to their household. You say, well, that's not good. Well, actually, it's not good. But what should strike you even more about this picture is what's in the forefront. Look at that. Those are solar panels that are driving a water purification system, and that is the tap operator. In order to get to the lake to get that contaminated water, this mother had to walk right by that water treatment system, right by it. And we've got to know why. And that's one of the things we're looking at right now is why do people make choices that they know are going to make them sick, and that happens all over the place. So that's one of the things we're doing right now. So then we did go back at the request of the Minister of Health to Project Cologne, and where we had a quarter of cases to find out because we were told that the pediatric death rate had dropped dramatically in Cologne since we were there. What we did is we found a control community. It's called Gracias a Dios, next to Cologne, and according to the Human Development Index, which is a composite index of things like education, income, and things like that, they're almost identical to each other. In fact, we began to track them to see if the HDI, Human Development Index, tracked really well with something like the health indices, and it did. Health indices is on the upright axis, and the Human Development is on the horizontal axis, and you see any increase in one results in almost a 1-to-1 increase in the other. Also look, I wanted just for fun to see if the other countries do the same thing in the region, and sure enough, they pretty closely do. Nicaragua has, because of some instability, had some glitches here in the early part of the years. They've tracked pretty well. Then you can look at other countries, again, just for fun, look at the Human Development Index, look at Cambodia. They look at Rwanda during their genocide, it drops way down over here, and it starts to catch up. So again, this is just seeing if other countries, if in other countries, not just in Honduras, the Human Development Index tracks the health index, which is a composite indices, and it turns out they do pretty well. So then what we found was diarrhea rates in Cologne dropped way faster. By the way, the whole country had some drop in diarrhea rates according to Minister of Health data, but Cologne had a much faster drop by the slope of the curve. You see, it's faster, and that did achieve statistical significance. We also we compared it not just to the Cologne, not just to the country as a whole, but to Gracias a Dios, this adjacent country with a nearly identical HDI, Human Development Index. And in fact, during that time, Gracias a Dios had an increase in pediatric diarrhea rates, while Cologne had a pretty dramatic drop. And we can correlate those fairly closely to when the water systems were placed in, and I'm going to skip through some of this for time. Then we began to look at infant mortality rates, and what we found was Cologne initially had an infant mortality rate that was right at the national average, but it dropped dramatically. In fact, it had an almost 30% drop in infant mortality rate when the rest of the country had a 15% drop. And we don't know what Gracias a Dios, because they didn't present data they didn't have data from 2005 and 6, but their final data was over 2.5 times what we had in Cologne, and what that translates is about 130 people, our infants, not dying during the time of this water systems replacement. So pretty good results in Honduras. Again, these are the issues we're wondering about, why we find differences in the two. But there's something else I want to show you that I think may even be more profound, because in Honduras we've got a grant to provide everybody with water. But I want you to picture this. Look at this map here of Uganda, and let's say that the white represents treated water with safe water spots, and the red is not treated water. And think about it for a moment. A child, how often does a child drink water? Let's say a child drinks water twice a day, 14 times a week drinks water. How many times during that week does that child have to drink from a contaminated water source to have diarrhea? Really just once. So one lapse out of 14. in a week period of time, the child has diarrhea, maybe just as much diarrhea as if they drank contaminated water all the time. So when somebody's moving through these areas like this, again, if this is a whites treated water, reds not treated water, as they start to move across these areas, they eventually start moving to areas where there's not treated water available to them. Again, the diarrhea rates will stay fairly high. As if you blanketed the area with water treatment systems, I call this the clustering effect. No matter where you go, you'll have treated water. And that's what you experience here in the United States. It doesn't matter if you're at the College of Charleston, you walk downtown to another building, you go to the library, there's always a treated water source there for it's safer. You don't go from a treated water source to an untreated water source. And I think in Honduras, we had that blanket effect. We did not have that.